Even okay. Hours. Hours. அதே லைன் வேற.
நம்ம ஷேர் பண்றதா இருந்தா இதை ஓபன் பண்ணணும்.
கொடுக்கல அக்சஸ்.
Send
சென்ட்
request.
ரெக்வஸ்ட்.
இங்க போனோம் சார்.
க்ளோஸ் பண்ணுங்க.
சேட் மெசேஜ் போட்டோம் பண்ணிக்கலாமா?
ட்ரை பண்ணுங்க. பிபிடி பார்த்துக்கோங்க.
ரெண்டுமே இருக்குல்ல.
சார் துரை சார், அழகு துரை சார். துரை. ஆமாம். முடிஞ்சிருச்சுங்களா சார் ஈவெண்ட்டு?
இது போட்டியா மியூட்டு?
ஓகே ஓகே.
மியூட் போட்டல.
ஓகே சார். ஓகே 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 ஓகே. ஆகாஷ் இன்னொரு 5 minutesல அனுப்புறாரு.
பண்ணிட்டாங்களா பேர்? சூப்பர். ஸோ முதல்ல இது செகண்ட்
ஸ்டார்ட் பண்ணிட்டு
வந்து
வரணும்பா.
ரீவே அப்புறம் பார்த்துக்கலாம். மூணு எங்கே இருக்குது? செகண்ட் ஒன் மியூட்டில் போடுது. சார் குட் ஈவினிங் சார். கம்ப்ளைண்ட் சார். சார் யாருமே மியூட்டட் சார். சந்திரா சார் Good evening. Good morning for you, sir. Yes, good evening.
Hi, good evening.
Professor Kamlesh Tiwari, Dean ICP is also joined, sir. So, you
Very
share
good,
something. Yeah.
very good.
Sir, meet Dr. Professor Chandra, sir.
Yes, sir. Yes, sir.
Hello.
Tiwari here, sir.
Good evening. How
Good evening.
are you?
Fine, sir. Fine. Thank you.
So, I'll start. You try from your side whether you can able to share the slides. We can run right now. Time is there. Otherwise, I can push your slides, sir.
Yeah, I think you can advance the slides,
Okay.
if you don't mind. Why don't
No,
we try?
I just try, sir. 1 second.
Yeah, sounds good.
So, you're
Yep, I can see the slide.
1
Yeah.
second, sir. Just try to check whether it's moving. Can you able to
Yep.
see, sir, now?
Yep, very well. Thank you.
Okay.
Great.
Yes. Okay. Just close for now.
So what is the format going to be, Suresh?
Short introduction by ICP Dean, sir, as well as the AP. Sir, AP President is joining today, sir. Kamlesh, sir.
I have asked Jyotimai to join, but he's
Okay,
busy.
sir.
He may join.
Yes, sir. So short introductions followed by your lecture.
Yeah.
And couple of cases you wanted to discuss, so I just put couple of cases for you. So I just show the cases, sir. Just for simple cases for postgraduates. It's not a complicated one.
Okay. Sir, this is a new concept. I have started this new thing in the ICP.
Yes.
I think
Yeah, this is great.
take benefit from this.
Yes, this is a great idea. Congratulations on trying to something new.
Thank you,
And
sir.
I'm sure that there will be people interested. I don't know how many people have registered. Certainly, anything I can do to help, I would certainly be willing to help.
No, it was more than 100, but let us see how many are joining here today.
Okay.
You can find out after some time.
You have a beautiful background there. Is this a real background or is this a fake background?
It is real, sir.
Very nice. Are you in your garden?
Yes.
Wonderful. That
Not
is
garden,
so.
just in front of garden.
Yes, beautiful. It looks
Thank you.
very nice.
Thank you.
I
Thank
love
you.
that fountain in the background there, and it's very nice. So, are you sitting outside?
Out in the veranda, yeah, in the corridor, you can check.
I see. It's beautiful.
Thank you, sir.
So where do you work, Dr. Tiwari?
Actually, I have retired now because I was professor in 3 medical colleges of Bihar, retired,
Okay.
became president of Association of Physicians of India in 21, and now I'm Dean Indian College of Physicians.
I see. How long is this position, the deanship in ICP? Is that for 5-year position?
It is 3 years, 1 year dean elect, 1 year actual dean, and 1 year past dean. So it is a
I
3
see.
years. 3 years.
I see. Great. So I was involved in starting infectious diseases as a subspecialty in India. So we're trying to do the same thing now in other countries also. So we're trying to do this in Sri Lanka starting this year.
That's very nice, sir.
Yes, and I'm glad that in India, infectious disease specialty is doing very well, and many people have chosen to subspecialize in infectious diseases.
It is becoming popular day by day, sir.
Yes, but I'm only hoping it will spread into the government sector instead of just remaining in the corporate side. And the government recognizes ID as a subspecialty like any other.
This is our first class in infectious disease.
Suresh,
Sir.
are you making sure that everybody else is muted during the lecture?
Yes, sir. They got
Yeah.
automatic settings there. We need to
Okay.
get permissions for you to share as well as thing there. So they'll automatically do it.
Okay. Okay. So my talk will be for about 35, 40 minutes. Is that okay?
Yeah, because I got a couple more cases to discuss. So yeah, fine, sir. We'll see number of questions also. Depending upon the time, we can cut down the case discussions.
Okay.
Good evening, friends. Today we are starting first class of infectious disease, and Dr. Chandrasekhar is here. He is the father of infectious disease in our country, and he's trying to do it in Sri Lanka as well. I think this is honor for us also because we are seeing him for the first time, and to help him, Dr. Suresh is here. So I think we can start the class now. Thank you, sir.
I sincerely thank the ICP Dean sir for giving this wonderful opportunity to start a certificate program training mostly medicine postgraduates. That's a good idea. We we think about in infectious diseases. And I thank Professor Chandrasekhar because he's very busy in his schedule. In fact, last week we tried to do, unfortunately, he was traveling. Unfortunately, he was traveling that time, but fortunately, he came back to his own place now. So, despite postponement, he still agreed for a talk. And first talk, because most of the highly trained persons are under the guidance of Dr. Chandrasekhar. Either we visited Detroit and got his guidance. Whenever he came to India, he guided most of the young ID doctors as well as physicians to learn more HD concepts and everything there. Sir is an alumni of CMC Vellore, basically native of Sri Lanka. That's why Sir is working on it, and is alumni of CMC Vellore. So settled in Detroit. Now he's Professor Emeritus of Medicine and Professor of Infectious Diseases Division there. And most of the Indian physicians know well Dr. Chandrasekhar, and most of the physicians also know well Professor Chandrasekhar. So this is an honor for us to have a first lecture by Professor Chandrasekhar. That's very well begin. The course will be go in the next 22 weeks. We are planning to start this course, and under his guidance and mentorship, and whenever is possible, sir, he can join and guide us and what next we can do. And a lot of postgraduates are interested in this course. And I sincerely thank the ICP Dean, and I hope Dr. Painappan sir, he is another Tamil Nadu AP's former secretary, but he is another initiative pushing this initiative for starting this infectious disease fellowship is the main pulpit in Tamil Nadu. I asked Dr. Painappan sir to give his words of wisdom before we start the program, sir.
Yeah. Can I see Palnippan? Yes. My friend Palnippan is here.
Yes, sir. Yes, sir. Please, sir. Yes, sir. Good evening, sir. Good evening, Dr. Kamlesh Diwari, sir. Good evening, sir. Good evening, everyone. Heartiest welcome to today's short certificate course from the Indian College of Physicians. Today we are having a infectious disease short certificate course. In that, actually, my dear friend Dr. Suresh Kumar is going to deliver the today lecture. So he is the key person in this master in doing this class. So infectious disease today, it's very, very important. Meaning complete physician, it's not complete. Actually, infectious disease, day by day, we are doing lot of new innovation during the COVID era also. Through myself and Dr. Suresh Kumar jointly released COVID protocol for the management of various COVID period, various protocol in Tamil Nadu API. And it's a very good teacher. So Dr. Suresh Kumar is a very good teacher. He's a pioneer teacher in infectious disease across India. And his words of wisdom is very, very important for the practitioner, especially in the ICU, any undifferentiated fever. Actually, some tips, history taking is very, very important. Any constitutional symptom, any travel history, or went to the beach or taking some Bani Puri, all the things, and some escort, some area. If you travel to that area, the particular disease is very common. So by means of the selection of antibody is very, very important. Sometimes serology may be negative. For example, scrub typhus, multi-organ failure, liver dysfunction, everything may be there. Scrub antibody may be mildly positive or may be negative. But history and clinical correlation, all the things is very important. And clinical assessment, detecting the S-score, all the things. So infectious disease, actually, if you were pandit in infectious disease, definitely any infection, gram-positive or negative or anaerobic or fungal or rickettsia or atypical mycobacteria, anything, any combinations also there, an appropriate culture, all the things he is going to elaborately discuss in detail. So that will be very much useful, especially in the ICU management. Selection of antibiotic is very important. One common terminology my friend Dr. Suresh Kumar used to use, short and sweet. Nowadays, 3 days antibiotic, 5 days antibiotic, 7 days, more than enough to treat. If you are bandit in infectious disease, definitely sepsis will not go for a severe sepsis syndrome. Severe sepsis syndrome will not go for the septic shock syndrome. Severe sepsis syndrome will lead on to multi-organ failure. because severe sepsis syndrome, 50% mortality, multi-organ failure, almost 80%, 75 to 85% mortality. So hit hard, hit fast rule also very important. Unnecessary antibiotic usage also should be stopped. Antibiotics, stewardship, everything you should know to be a complete physician. So we are awaiting to hear from my dear friend, Dr. Suresh Kumar. Over to you, Dr. Suresh Kumar.
Sir,
All the
thanks.
very best for the 20 classes on infectious disease.
Thanks, sir. Thanks for your kind words of wisdom. One small change today, not I am doing it there. Professor Chandra is doing it there. He is my mentor, he is my guru and everything. Sir, this is without further ado, I don't want to stand in between Professor Chandra and students. Sir, this is your time. Stage is set for you, sir. I can start moving the slides, sir. Sure.
Great. Thank you. Thank you, Suresh. Thanks to Dr. Suresh Kumar and to ICP for inviting me. This is about 9 o'clock in the morning where I am sitting in Detroit, Michigan. It's very, very, very cold here. We have 6 inches of snow in the ground, but thank God I'm comfortably seated inside my home in a warm room. Let's get to the talk. When Suresh called me and said, would you please give a talk? My question was, who is going to be the audience? So the audience here, I see there are about 85 participants. Welcome to each one of you. And he explained to me that most of the people here are not very familiar with infectious diseases being practiced as a subspecialty. So he asked me to give an introduction to what an infectious disease guy does on the floors or in his office. So that's what my talk is going to be. So as you can see in the title, approach to a patient with an infection in clinical practice. So I just want to inform you, or you probably are already aware, that infectious disease is a very well-developed subspecialty in several parts of the world, including the United States. In India, the subspecialty was literally created about 2 decades ago. And it has grown very nicely, but it's still many parts of India, there are no infectious disease physicians. And most of the physicians, as you would expect, are concentrated in major cities. So there is a major shortage of infectious disease physicians in various parts of India. So this talk is primarily to make you understand how an infectious disease physician's mind works when they approach a patient either in their office or in the hospital. Okay, it's a very basic talk and it's a broad talk, and I would like you to listen to it and let's discuss it at the end if you have any questions. Okay, so let's get started. First slide, please. So if you look at infectious diseases, they are extremely common, right? The most common cause of mortality in many parts of the world remains infection, not cancer, not autoimmune diseases or any other. Trauma and infections are still extremely common in many parts of the world. But fortunately, most infections that occur, both in children as well as in adults, are self-limiting. So people get over the illness. They don't even seek any medical help. And many do not require antimicrobials, and most do not require hospitalization. So it's very important for the physician to be aware of these simple facts to keep in mind and not to hospitalize the patient unnecessarily or to initiate antibiotics where antibiotics may not be required. And many are preventable with effective vaccines. And many are transmissible. Hence, there is a very important public health component. And these are very unique. This is not true for patients with cardiological problems, patients with nephrological problems or pulmonary diseases. This is very, very unique to infectious diseases. There is no other area where you use a vaccine to prevent an illness. There is no other area where the disease spreads from one individual to another, and where the antimicrobial use here may lead to resistance arising within the pathogens. This concern doesn't exist in cardiology, rheumatology, or pulmonology. So these are very unique issues to infectious diseases. Okay, next slide, please. Okay, yeah, this is the next slide, correct. Thank you. So if you were to encounter a patient with an infectious disease, what is the area that would be most important? Here, as you can see, history is highlighted. Among the various areas, history, physical exam, and laboratory exam, history appears to be the most important. Dr. Palaniappan, in his introductory remarks, mentioned the same thing. He highlighted the importance of history taking and the various aspects of history in arriving at a suspected diagnosis. Okay, the best tool we have is history, and unfortunately, this fact is often forgotten. We are all in a hurry. We want to make a quick diagnosis, both in the inpatient setting as well as in the outpatient setting. And we want to initiate therapy. So we hurry up and make a diagnosis with very limited information, which is the enemy of infectious disease. We cannot afford to do that. We have to take our time and take a careful history, because we do not have many fancy laboratory tests to make an accurate diagnosis of infectious disease. The tests are very limited in number and their capability. So if you don't suspect an issue, if you through a careful history, you may not be able to order an appropriate test. So if you don't order the appropriate test, you will never make the diagnosis. So in order to be able to order the appropriate test, you have to suspect a certain disease. We cannot use a shotgun approach and order a multitude of tests. That's a waste of our resources. So in order to be pinpointing the exact diagnosis, history would be the most critical. And I can't tell you how important this is. In fact, in the entire presentation, this is probably the most important slide. History is the most useful, least expensive, and most underutilized. Why? Because we are always in a hurry. We don't want to sit in front of the patient and talk to the patient. That has not been our culture, at least in the last 30 years of allopathic practice. We have changed. We are always very quick in jumping to a diagnosis. And as you will see in a few minutes, that can lead to erroneous diagnoses. So when I say history, you can see the last bullet: details of the chief complaint, past history, family history, travel history, exposures. They may have gone to Kumbh Mela, some festivals, some family members may have arrived with illness at home. Pet history, what kind of a season? Is this a winter season? Is this a summer? Did they have any procedures recently? Any recent hospitalizations? What kind of a lifestyle they may have? Do they have injection drug use in their history? Are they gay men? What sexual history? What is their occupation? What kind of immunizations the person has been previously exposed to? What is their underlying immune status? Are they on steroids? Any other medications that may suppress their immune status? All these become very important features in arriving at a narrow diagnosis. Okay, so if I'm having a conversation with a cardiologist, a rheumatologist, a pulmonologist, certainly in their training, they do not take such a detailed history. They will take a detailed history as far as their chief complaint goes, but they are not going to be too concerned about what season it is, or whether the patient is an injection drug user, which may or may not have a direct bearing on their area of interest. Whereas in infectious disease, all these play a very important role, either directly or indirectly, in making a diagnosis and in optimal management. Okay, so this is, in fact, this bullet doesn't even contain all the pieces of history. This is only a partially important. In fact, I can go on and on about various aspects in the history that would be important to be sought after. Next slide, please. So I'm not saying this, I haven't invented anything. Dr. William Osler, Sir William Osler, as you know, the person who started Johns Hopkins Hospital in Baltimore, Maryland, many years ago. He lived in the last century, and he's considered the father of medicine. And he's the main person who was involved in writing the book Harrison. He was involved in it. And as you can see, he said, listen to your patient. He's telling you the diagnosis. And this was uttered over 100 years ago. And this remains very true. At least in my practice of last 40 years, I can tell you, if there is one aspect of clinical medicine that is important, it is the history. Not the CAT scan or the PET scan or the PCR. It's the history. Next slide, please. Physical exam. What is important from the physical exam from an infectious disease doctor's viewpoint? There are only two things that are critically important. How does the person look? Does the person look ill, or does the person look okay? Most people with infections look ill. If they have a cold, if they have a cough, if they have a fever, they don't look very well. So just the initial casual appearance itself will give you a clue that this patient is likely to be having an infection. On the other hand, if the person is saying, I have a fever, and he's sitting in front of you, talking comfortably with no evidence of signs or symptoms, and carries on, that person is unlikely to have an infection. And that fever the patient is complaining of may be due to a completely different etiology, such as an autoimmune illness or cancer. And that is less likely to be due to an infection. So the simple appearance of the patient provides an important clue for you to suspect the possibility of an infection. 1. 2, vital signs, extremely critical. These days, when my junior physicians present cases to me, they don't even mention the vital signs. Vital signs are absolutely critical. As you can see, the temperature, pulse, respiratory rate, blood pressure, and the O2 sats. These are absolutely critical, basic clues for me to suspect the presence or absence of an infection. Okay? Other than these two things, how does the person look and what are the vital signs? Rest of the exam is not that critically important when you're dealing with an infectious disease. Yes, I'm exaggerating. There may be important clues, but in general, how does the person look and what are the vital signs will help you decide, do I hospitalize this patient or not? Do I initiate antibiotics or not? To answer those two critical questions, all you need is appearance and vital signs. Okay, I hope I have made that point across very clear. Now, let's go back to that one more second, Suresh. Yeah. So HENT, cardiopulmonary exam, abdominal exam, genitourinary exam, CNS exam, all these are important. Okay, but they are not as critically important. These areas you can concentrate on depending upon the symptomatology. If the patient complains of symptoms that may relate to the respiratory system, by all means, you would pay close attention to examination of cardiopulmonary systems. If the patient complains of abdominal pain, obviously you're going to be paying a lot more attention to the abdomen. Okay, so I'm not saying completely ignore the other areas, but pay particular attention to the appearance of the patient and vital signs. Next slide, please. Laboratory exam. You have finished your history taking, a detailed history. You've done your examination of the laboratory exam. We do not have to order all the tests at once. At the end of the exam, you may have arrived at a certain clinical diagnosis, suspected diagnoses. So your initial workup may include a complete blood count, a hemoglobin, a white cell count, a red cell count, a platelet count, electrolytes, blood urea and creatinine, and simple liver functions. That's all you need. You do not have to order all the tests at once. So when we teach our younger physicians here in the United States, this is what we emphasize to them. You have to justify every test you order. Why do you want a certain test? And if you think you want to draw 50 cc's of blood and do all the tests, that's an absolute waste of resources. The tests may follow in a logical fashion as the case develops gradually. Okay? And urinalysis, urine culture, blood culture, these may be ordered if you find them to be appropriate. If they're compatible based on your history and physical exam, if your suspicion is strong enough, by all means, you can order the appropriate tests. But what I'm trying to make a point is, don't order all the tests at once, and they can be staggered over a period of time. Next slide, please. Imaging. What do we do with imaging in terms of an infectious disease physician approach? Most of the times, we may obtain a chest X-ray, again, if it is appropriate. These days, people have started using CAT scans, MRIs, PET scans, nuclear scan, etc., for aiding in the diagnosis. Yes, they may play some role, but certainly not in the first visit, not in your first go-around of testing. Okay, you have to ask yourself, again, justify, number one, the cost of these tests, they're expensive, and number two, the limitations of the test. Okay? Don't believe that that is going to give you the absolute answer. That is going to be another tool in your toolbox in order to arrive at a diagnosis. Okay? For example, in India today, PET scans have become extremely common to look for a focus of infection. In the United States, less than 1% of the times we would use a PET scan for infectious disease. It is not approved. The insurance companies won't pay for it. So please understand, when you're ordering these new tests, they have severe limitations, and there is very little evidence in the literature to support many of these fancy tests. For example, the nuclear scan. Nuclear scan has been given up in Western medicine many years ago for identifying infectious focus. But still people do it. Let's do a gallium scan. Let's do an albumin tracer. Let's take the white cells, tag them with albumin, and shoot them and take a scan. These are extremely commonly done with very, very little in return. So you have to be somewhat aware of these major limitations of these fancy tests. You don't need them. Once again, if you have a good history, that's 90% of the job. Okay? Molecular studies, same thing. We do a ton of PCRs today. Now, the pharmaceutical companies and the companies that make these products have a lot of products for BioFire, for example, a company. I'm just picking that company. There are many, many others that have PCR panel for respiratory panel, PCR panel for stools, GI panel. And like that, there's a PCR panel in the CSF. This takes away our thinking. We have to be able to focus and give a narrow diagnosis because these panels contain 15 to 20 different pathogens. This completely takes away our thinking. And very often today, we get answers that come back with 2 or 3 pathogens in the CSF. And you are left to struggle to make a sense out of those results. How do I interpret now? I see pneumococcus on the PCR, and at the same time, I see West Nile virus. How do I interpret this? So you're left with the task of difficult interpretation, or you end up treating multiple pathogens unnecessarily. So PCR, you have to be careful. And presence of PCR, if you detect PCR, remember, PCR detects both live pathogens and dead pathogens. So you do not know if the PCR is positive. Am I dealing with a dead organism? Is the Mycobacterium TB dead? Or is the Mycobacterium TB alive? PCR will not tell you that. Only a culture will be able to make that distinction. So these tests, although they're very useful, very fancy, but they have major limitations. Next-gen sequencing, I don't know how many of you are familiar with this. This is looking for like a needle in a haystack, okay? Small amount of genomic material of the pathogen is looked for in a person's blood sample if you're stuck with the diagnosis. I had a patient 2 weeks ago. It was a post-stem cell transplant patient with fever. I did not know where the fever was coming from. After careful exam, after 10 days of fever, I still couldn't make the diagnosis. Finally, I requested this metagenomic sequencing, and that revealed the patient had reactivation toxoplasmosis. Okay, so yes, these tests are extremely valuable, but in a limited fashion, and not certainly at the beginning of encountering the patient and not in the initial visits. Because these are costly and they have limitations, and many times they create more problems than provide solutions. But certainly they do have a role in infectious disease. Serology, it's becoming more and more obsolete. We're using less and less serological methods as we have more and more molecular identification or blood culture identification of the organism. Serological way of making diagnosis is becoming less and less. Yes, we do have it in certain situations, but gradually, I think in the next 10, 20 years, serology would disappear. Invasive tests. Should I order a laparotomy? Should I order a thoracentesis? Should I order an lumbar puncture? These you have to consider how important they are. And you need to perform, the people who are going to be performing the test, you need to have a discussion with them. For example, you want a lung biopsy to make a diagnosis because there was a mass in the lung. So you need to go sit down with the surgeon who is going to be doing that procedure and say, you know, where is the best yield? Which part of the lung should I go to? Should I go to the lingula? Should I go to the right lower lobe? Should I go to the apex? Yes, the CAT scan is showing me certain areas, but where do I think would be the best yield? So it's always good to have a discussion with other team members, particularly if they're going to be performing the invasive test. And once the invasive test is done, let's say a lumbar puncture, and you have 10 cc's of CSF. What do I send the CSF for? You will send it for the routine. You will send protein, glucose, white count, gram stain, AFB stain, culture. What else do I send it for? Should I send for panel, PCR panel? Do I send? No, you don't have to. You can save the CSF. That's why I put save specimens and an exclamation mark. Save the specimens. Learn to tell the lab to preserve those specimens. And 2 days or 3 days later, when I still haven't made a diagnosis, I can go back to those specimens and order those extra tests because they're expensive and they may not be needed unless you're pushed to the point you don't have a diagnosis and you have to go back to the specimen. Saving the specimen often we don't remember to do. So you don't have to order all the tests right at the beginning. These may seem like very simple principles, but these simple principles, if practiced regularly, it helps you a lot. Okay, next slide, please. Diagnosis. Okay, this is our ultimate. This is what we live for, to make a diagnosis so we can provide appropriate management. So what I do when I approach a patient after my history taking and physical exam, I try to summarize with these 3 questions. Where is the problem? What is the problem? Why is the problem? First one represents anatomical diagnosis. Second one describes the pathological diagnosis. And the third one tells you what is the etiological diagnosis. Once you know the etiological diagnosis, you're ready to write the prescription. So arriving at the etiological diagnosis is the hardest, the why question. Why do you have the fever? Where is the fever coming from? Is it the chest? Okay, maybe chest is the problem. What is the problem? Patient has fever, purulent sputum, chills, and has been going on for the last 4 days. Okay, most likely it's an infectious disease. So I have made an anatomical diagnosis. It's likely coming from the chest. Most likely it's an infection. What is the infection due to? Is the etiological diagnosis. And that's usually the hardest one to arrive at. So this is the way my mind works when I'm approaching a patient at the bedside from an infectious disease standpoint. Okay? The same thing, a different approach here, problem representation. As you can see, you summarize it, and the summary of the problem will consist of what type of host, what is the tempo of the illness, is there a syndrome? This is important. Most of us use the term syndrome, not quite understanding the meaning of the word syndrome. Syndrome is a Greek word, a combination of sun and dramain. Sun means together, dramain means to run. So it's actually to mean the signs and symptoms of the patient if they run together, compatible with each other. That refers to a syndrome. So if in your mind, after obtaining a careful history and doing a physical exam, if you felt the signs and symptoms are running together to remind you of a certain syndrome. And this is what we call a syndromic approach. Okay, most of us practice like that. We have a syndromic approach, putting the signs and symptoms together based on the history and physical exam. Another approach is the checklist approach. Here, you look at all the signs and symptoms and build a differential diagnosis for each of these features, and then cross-reference for these differential diagnoses and see where do they all meet in the cross-reference. And that meeting point gives you the diagnosis. Okay, this is another approach. So we can either make a diagnosis through a syndromic approach, which is what most of us do, in an intuitive way. In an intuitive way, we arrive at a syndromic approach. If the signs and symptoms don't run together, they don't remind you of a certain syndrome, then you use the checklist approach. And the checklist approach is, okay, what are the main signs and symptoms? And let me build a different diagnosis for each of these. And let's look at these different diagnoses. Where do they all cross? And what is the meeting point? That would give you the diagnosis. Okay, this is essentially how the human mind works in arriving at a diagnosis of a problem. Next slide, please. Early diagnosis is a very common cognitive error. Yes, I put in the slide, I was asking myself, what is the biggest mistake we make in arriving at a diagnosis? This is what is called anchoring bias. What is the anchoring bias? We're in a hurry. We have 35 patients to see in the clinic, and I am patient number 3. I am in a hurry. So I listen to the patient's initial symptoms, and I'm in a hurry. I make an early diagnosis. That is, it's a typhoid season. Everybody has typhoid. The patient comes to me with fever, and a patient hasn't eaten, patient is ill. So I make a quick diagnosis. This guy has typhoid. So early diagnosis is a common cognitive error based on the first piece of information you receive. So with very limited information, you hurry up and make a diagnosis, and that is what is called the anchoring bias. You anchor your diagnosis based on the initial symptoms, and worse than that, even as you get more and more new information coming in, you still refuse to change your original diagnosis. That is called confirmation bias. So most of us, because we are in a hurry not to obtain a detailed history, with an anchoring bias, make an early diagnosis which may be wrong. And that is further accentuated with confirmation bias, because even when we get new evidence coming in, we do not consider the new evidence in order to change our original diagnosis. It's called confirmation bias. And these are two of the most common biases clinicians have when dealing with patients, particularly in infectious disease. So you can see the last bullet, 800,000 Americans annually are either permanently disabled or die due to diagnostic errors. Next slide. Just want to share a paper looking at this paper, which was published 15 years ago in the Archives of Internal Medicine. There's a review study of nearly 8,000 patient records performed in Europe. And you can see there, nearly 85% of diagnostic adverse events were preventable. The consequences of adverse events were more severe than for other adverse events. And the last bullet is the most important. The causes of these diagnostic adverse events were mostly human, main cause being knowledge-based mistake and information transfer problems. As you transfer information from one physician to another, in the inpatient setting particularly, if it is inadequate, if it is inaccurate, we make errors in our diagnosis. Okay, so this happens every day in the inpatient and outpatient setting. Next slide, please. Okay, so now what do I decide? How do I decide? This is either hospitalization or not, antimicrobial treatment or not. I need to take into account oral versus IV, narrow versus broad spectrum, cost, side effects, antimicrobial resistance, duration of therapy. All these have to be taken into account. Okay, now duration of therapy, as Dr. Palaniappan mentioned, 3 days is becoming more and more popular. So recent data shows many of the infections may be adequately treated with shorter duration. This needs to be kept in mind. So these are the decisions one would have to make as an ID physician. 2 questions. Do I hospitalize the patient? Second question, do I initiate antibiotics or can I wait? Initiating antibiotics without a diagnosis is called empiric therapy. Patient may demand, he may need the drug right away. Doc, give me the drug. I don't have money or the time to come back for a second visit. Please give me treatment right now. That is the pressure the physician is under. However, the diagnosis may be wrong or the diagnosis may be obscure. That is the risk you take by employing empiric therapy. In general, we try to discourage using empiric treatment. Definitive therapy based on definitive diagnosis is almost always a commendable thing to do, the right thing to do. However, we are all under pressure with limited information to come up with a diagnosis and to come up with a treatment plan, which may or may not be accurate. Next slide, please. Optimal management of infection, as you can see, it's a patient-centered approach, flanked by the primary care physician, the consultants, including the infectious disease consultant, pharmacist, microbiology lab, radiological information. All these go into play in doing optimal management. You're not working in a vacuum. So very frequently as an ID guy, I would walk over to the micro lab. I would walk over to the radiological suite. I would go to the surgeon's office, or at least I'll give him a call. I'll talk to the pharmacist. These conversations occur on a daily basis. So we all touch base about the information, exchange information, so we come up with the accurate diagnosis and the best possible treatment. And many times I do not use the phone. I try to meet them in person and talk to them in person, not communicate through phone or through chat. And what I find today, we spend little time with the patient and family to explain to them what is going on. It is not over their heads. They should be able to understand, provided you use the right terms to communicate with the patients and their family. This is a very, very important factor in order to get compliance from the patient, adherence of the patient to the medications, because they understand what is the diagnosis and how best it can be treated, unless and until they complete the course of treatment. So explaining to the patient and family is extremely important. Next slide, please. Hospitalizing patient with an infection. Now, what if the same patient is in the hospital? Now you're approaching this patient to look for a fever, okay, to look for an infectious cause. Here you can see this patient has bacteremia or fungemia, or it could be drug-related if there is fever. And the likely foci in a hospitalized patient as compared to an outpatient setting, it would either be the post-surgical wound, or the patient may have a respiratory tract or a urinary tract infection, or it may be an IV catheter-related infection, or a patient may have diarrhea, which may simply be antibiotic-associated clostridial infection. Okay, these are the likely foci that may cause fever in a hospitalized patient. It's very easy to come up with a diagnosis of infection in a hospitalized patient because they're very limited in number, as you can see from the slide. Or the patient may have acquired a problem within the hospital from a nurse or from another patient or from a physician. He may have acquired COVID or influenza inside the hospital. Or finally, the patient may have a dormant disease which may have decided to be reactivating in the hospital, such as tuberculosis, which is less common. What about non-infectious etiologies mimicking an infection? Very important, but often forgotten. Can drugs are playing a role in this patient? Is cancer maybe playing a role? The fever with lymphoma, or if the patient have dead tissue that need to be debrided, presence of the dead tissue or presence of a blood clot may be giving him the fever, or hemorrhage may be giving him the fever. So all these non-infectious etiologies should also be in your consideration while approaching the possibility of infection in a hospitalized patient. Okay, and finally, autoimmune etiology. So this is an important slide, and this distinguishes approach to infection in a patient who may be hospitalized as compared to a patient you may see in the clinic, okay, which is a completely different approach. Next slide. What if it's an immunosuppressed patient in whom you're thinking of infection? What is immunosuppression? A cancer patient, a transplant patient, patient who may be receiving immunosuppressive drugs, neonates, elderly, all these are immunosuppressed people. And in those patients, in addition to common infections, you would also consider as you can see, opportunistic infections such as Candida, other fungi, nocardia, mycobacteria, and so on. So in an immunosuppressed patient, the list of possibilities increase. So you need to keep that in mind. Okay, next slide, please. These are special situations. So the flaws in the ID management in general, too little history, too little time. In government hospitals, there is too much empiricism. We do not have time to make a diagnosis. We do not have time to take a detailed history. In private facilities, too many lab tests, unnecessary broad spectrum drugs are employed. In the outpatient setting, again, too little history, too much empiricism. Emergency rooms, too much empiricism. As a consequence of this empiricism and a lack of diagnosis leads to misdiagnosis, antimicrobial resistance, drug adverse effects, and of course, increased cost. Next slide. As I mentioned earlier at the beginning of my talk, infectious disease doctor, what they deal with are completely different from all the other subspecialties for the reasons shown on this slide. Okay, infectious disease has a public health importance. No other area we worry about transmissibility of the disease. No other area we worry about epidemics of a myocardial infarction or epidemics of COPD. We don't worry about it. Whereas in infectious disease, we worry because of the possibility of transmission, epidemics, pandemics, travel health, pet hygiene, contaminated consumption of commercial food products, water supply being contaminated. All these become very important within the purview of infectious disease physician. And these all have impact on the overall management of the individual patient and the community. And when we use antibiotics, they have direct impact on patients' gut microbiome. And these will have consequences either directly or later on. And also, inappropriate excessive use of antimicrobials may lead to resistance and eventually loss of use of a very valuable drug. These are all potentials directly associated with an infectious disease physician's practice, which is very, very different from other physicians approaching their patients. Next slide, please. So in summary, history is very critical for diagnosis. Take the time for details. Many infections are self-limiting. We do not need empiric therapy unless the patient is very sick or if the patient is very immune suppressed. You may not be able to withhold empiric therapy. Antibiotics are useful, but consider cost, resistance, microbiome change, adverse effects, and public health impact. Finally, don't forget vaccines. Vaccines are heavily underutilized. You must always remember in every patient's visit, whether it's a pediatric patient or adult patient, that is a golden opportunity for us to administer the appropriate vaccines. In the United States today, with the Trump era, there is a major problem with vaccine acceptance in populations. Measles have started appearing in various states. There is concern polio is coming back in the United States because of people's losing faith in vaccines. It is our responsibility to convince the public vaccines are extremely useful. They have made a huge difference in reducing the frequency of infection in the last century. And it's our job to administer vaccines at the appropriate times. Next slide. Finally, I want to leave this once again with Sir William Osler's statement, good physician treats the disease, the great physician treats the patient who has the disease. So always consider it's a patient-centered approach. I think I'll stop my preaching at this time. Thank you for the time. If I have gone a little bit excess, I'm sorry. Suresh, over to you.
Thank you, sir. Thanks for a wonderful presentations. It made the crux of infectious disease, how we make the diagnosis and what we do for antibiotics and everything. To show more importance of this one, I'll share very quickly couple of cases, practical cases, and just show what is your input as well as I need to get the audience input, because postgraduates need to answer not only by engaging today, but you need to answer this queries so that you can get a good certificate as well as good marks also. We are planning to do it. I hope my slides are visible now. So
Yes.
yes, I'll show a couple of slides there. So nowadays we can do with anything with the AI, but this presentation is not made by AI. This is made by me. So what I'm going to do, the approach Dr. Chandrasekhar, even though he's practicing from US, he talked about Indian scenarios. We need to shoot the diagnosis with a simple history taking and physical examinations and basic lab. So we are going to shoot a couple of cases based upon this talk. My first case is here. This is a case here. This is a young guy, 28-year-old male. Basically, he's working in Chennai, native of Bangalore. He got fever of 8 days durations. The fever is a high-grade fever associated with headache. The fever is present throughout the day. It's not an intermittent fever. This is a continuous fever. He has diarrhea also for 4 days durations, 4 to 5 episodes, more of watery in nature, no blood or no mucus, mild abdominal discomfort, no vomiting. No other significant positive symptoms, no dysuria, no skin rash, no joint pain, no other things there. Past medical history, he has similar history in the past 2 months. Every time he sustains, as he rightly pointed out, he goes to some general practitioners. He is given empirical therapy with some antibiotics. His fever subsided. He started going for work and started continuing the work. He started levofloxacin this time without any further test. And what empiricism we do not know. Is native of Bangalore. He's working in Chennai. On examination is febrile. The temperature is 1 or 2. Spleen is just palpable. Rest of system examinations was normal. There's no neck stiffness, no CNS or no other systemic examinations findings. So I'll ask the postgraduates, you can put it in the chat box. I initially wanted to open in a multiple choice questions in the online format, but slightly the time was delayed, so we didn't able to do it. I like to see how many postgraduates responding before Professor Chandra sorted out this case there. So what's your approach? People put one as a choice so far. People put all. People put one. Mostly preferred choice is one or all. When we give MCQ all of the above, none of the above, people always tempt. So people now put all of the above. Professor Chandra, what's your thoughts? How to dig this type of common cases seen by postgraduates in their OP?
Yeah, this here again goes back to history. And here you've told me this is a young man and has a fever for the last week or so in combination with headache and GI symptoms with diarrhea, loose stools. And on physical exam, the patient has a splenomegaly. Here, my first thought would be, am I dealing with salmonellosis? Am I dealing with enteric fever in this patient? Why do I think of enteric fever? Because he's in Chennai, he has fever, and he's got loose stools, and he's got a splenomegaly. So I would say, well, is this a problem? I need better history. I need travel history. I need any sick contacts. I need more information. However, in my mind, if I think of GI-related illnesses as the background for this patient. So where is the problem? I think it is the GI tract. What is the problem? I think it's an infection. Why is the problem is the hardest one to answer. So I would need more answers to my questions. So I would say, can I have more information about the patient?
He is native of Bangalore, staying in Chennai, eating all sorts of food in Chennai, tasting everything, particularly Pani Puri, his favorite food there. So, and the illness has improved with last couple of days, he improved with cefixime, third generation cephalosporins. So, but the course is only 5 days is completed. This time levofloxacin is taking. So these are all the histories I can put it right now.
Yes.
No sick contact.
Sorry?
No sick contact, no pets.
Correct. Yeah. Okay. So with this approach, with this history, I would want to make sure We are not dealing with an enteric fever in this patient. That would be my approach. So I would say let's get some basic labs.
So yes, rightly pointed out GI system in a person staying outside the home, eating outside food there. So people always do Vidal test. What is your thoughts on Vidal test? How significant single Vidal, Dr. Chandra?
Well, I'm the wrong guy. You guys see typhoid all the time. We do not see typhoid in this part of the world as much. My understanding is Vidal is falling out of favor. We do seldom use Vidal today to make a diagnosis of an acute febrile illness, such as salmonella. So Vidal has fallen out of favor, and I generally do not use this tool for diagnostic purposes.
So the basic idea is to show this Vidal test is a useless test, particularly single Vidal we are meaning it about. That's why we just put this case. Vidal has got very limited value. We don't rely on the Vidal. So we need to think about a syndrome, as rightly pointed out, more history. Since he's eating out, he's a young guy and he has got fever, spleen, and levofloxacin. The problem is now ciprofloxacin, levofloxacin has got more resistant to typhoid. So that's a problem we are facing now. So this is a clue we got it. Young guy, most of the time typhoid is possible. Staying away from home, eating outside food, fever lasting more than 7 days. This is not virus to me. This is bacteria. Diarrhea plus spleen, no response to levofloxacin. Usually the fluoroquinolones has got more resistance in India. And recurrent fever, short courses of treatment, not completing the full courses for typhoid is getting back. That's the reason this is a case of typhoid, already pointed out by Professor Chandra there. Since we are running next.
Yeah, here again, I just want to point out, Suresh, in my diagnosis slide, I said the syndromic approach. This is, again, remember the word syndrome, running together. If signs and symptoms run together, it reminds you of the syndrome. Here, the signs and symptoms beautifully run together in this young man in an area endemic for typhoid. And with the patient has features suggestive both symptoms as well as signs by way of the fever, the recurrence of the fever, and the splenomegaly. All these put together, it's syndromic approach. One will easily arrive at the diagnosis of a GI illness, likely from salmonella.
Thanks, sir. You already nailed it in your first talk itself there. So these are all the history we need to ask for it. So this is another case. Here is another young male, but is a diabetic, fever of 4 days durations, high-grade fever with chills, body pain, back pain, headache, vomiting. It was apparently normal. This is a sharp onset of fever, no sick contact. But he recently traveled to hill stations with a lot of mosquitoes. He got mosquito bites. On examinations, febrile, his vital states were normal. Rest of system examination is also normal except the skin. I have shown the pictures, but it's not clear. So I'll show a next picture. But he did the dengue test on day 3, day 4. That is negative. And this is another picture for much better idea. So what will you do? The postgraduates keep answering so that meantime Dr. Chandra will dissect this case. Postgraduates, please engage. So what is your choices there? Young male with a hill station travel, a lot of mosquitoes bite, fever, headache, sharp back pain, typical bend like typical severe back pain, not able to lift. That's this back pain is complaining. Pain behind the eyes, diffuse rash with some clearing of the skin on day 4, day 5. Normal skin start appearing between the erythema. That's first picture. The second picture is initial pictures, day 2, day 3, where a lot of erythemas and blanching on putting a hand.
Very good. Okay. So here again, it's a fairly straightforward. It's a 30-year-old person with diabetes, fever going on for under a week with body and back pain. The pain seems to be disproportionately severe. A patient has headache and vomiting. They said severe back pain, retroorbital pain, and the patient has already volunteering a history of mosquito bites. So one has to, and in the correct season, one would certainly include dengue in your differential diagnosis, particularly considering what part of the world we may be dealing the patient, where the patient might be in. So here, in addition to other mosquito-borne illnesses, you would want to include dengue in your differential, and that gets even more prominence with the presence of this rash. So going down the list, dengue becomes important, and the dengue serology may or may not be very reliable at the early stages of the illness. So you may have to repeat the serology, as option number 4 suggests. One may be able to eliminate other possibilities and order fewer tests in order to nail the diagnosis.
Rightly pointed in your presentation, serology take with a pinch of salt. That is the problem here. That is the idea of presenting this case. Always don't rely more on serological tests. Go with the clinical picture. Nowadays, PCRs are available for dengue also. Yes, think about it. Suppose serology doesn't give you a clue to you, a clinical diagnosis. So basically, this is a dengue, the initial stages of diffuse maculopapular rash, and later stages, the normal skin start appearing. That's called area of highlands, we can call. That is classic sign of dengue. Sometimes Zika, because nowadays we start seeing Zika in Pune part. So think about it. That also is possible. So detailed head-to-toe examinations always give you a clue. Since we are almost reaching our time, last case I just show in a minute. So this is farmer from South Tamil Nadu, back pain, body pain. Almost all the system is affected. Cough with minimal expectorations, shortness of breath, confused, tachycardic, hypotensive, tachypneic, got some node, occasional crackles on suffixime on day 7. It's not improving. So we need to rely on the antibiotics history also. That is more important. But right now, what you need to do, whether you want to take more history, more examinations, or basic labs, or stabilize this patient, or start antibiotics. Participants, please vote. So we just think about it. Next time onwards, we'll give you choices to you to enroll so we know who is answering and who is not answering there. This is the first time we are presenting, so we're not able to do it this time. So what do you think about it? Rural background, farmer, almost all the system is involved, but no water exposures. So no walking in the rainwater, wading in the rainwater, but he is a farmer and he got a lot of bushy areas exposure in the farming land. Yes, Dr. Chandra, words of wisdom.
Go ahead. Well, we're running out of time. I'm seeing a lot of options in the chat.
Yeah. So this is an HCAR we find out. So based on the history, more than 7 days, it's not viral. Farmer, no water exposures, bushy area exposures. Think of scrub typhus. Always look at it. All organs are involved. But first thing, stabilize the patient because the patient is sick, confused. Person is tachycardic, hypotensive, tachypneic. When to admit the patients? Dr. Chandra clearly told when to hospitalize the patients and when to start antibiotic. The threshold we need to decide. That is the aim of this case, what we did now. So we need to know when to approach. Vital parameters, that's most important. When the vital parameters is unstable, when the person not able to give the history, confused, stabilize the patient. Don't look for history, don't look for examinations, stabilize the patient. That's more important. Hospitalize or stabilize, that's most important thing you need to keep in mind. So with that, we need to take home messages. Proper history taking is vital in infectious diseases. Patient is telling the history. Unfortunately, we are looking at some other side. That's the problem we are facing. That's what clearly told. The differences between good and great is how much time we spend on the history. Clearly shown. So I'll open to the questions because if you attend the certificate course like Professor Chandra's classes, your patients, whether you are make money or not, but your patients will definitely go back home with a lot of money what he came to the hospitals. Otherwise, he don't have money. He may be live, but he don't have money to go home. That's a problem we are facing now with a lot of tests and other things. Those who want to learn more, please scan this QR code to learn more it. Meantime, last couple of minutes for any questions so that we can ask Professor Chandra whatever things you want to sort it out in next couple of minutes. Please go ahead, put it in a chat box so that I can ask Dr. Chandra there. Meantime, I'll check with him. Okay. So how much minimum history you think, Dr. Chandra, is essential in a busy government setup? You know, you worked in CMC Vellore. The government sector PGs, they need to see almost 50 to 100 odd patients in a OP setting. So how much time or how much minimum history they need to elicit because they need to make a decisions to admit the patients or not? How much history you think is essential to make a diagnosis in busy OP setting in government hospital?
I know it is tough It's a very big challenge. Just to give you an example, in my practice here, if I have a clinic, outpatient clinic from 8 to 12, let's say half a day on my Thursdays, I am scheduled to see about 12 to 15 patients over that 4-hour period. And I can imagine the number of patients that will be scheduled to see you in your 4-hour clinic will be in excess of 25, 30 patients. So you are under a lot of pressure to make a quick diagnosis, and this is the downside. So all what I can appeal to you is use the two things, the vital signs and the appearance and a brief history. And you have to make a diagnosis. If you say, I cannot make a diagnosis, do I hospitalize this patient? So that I don't miss the diagnosis, particularly if it's a serious diagnosis. So your main job is to, one, do I hospitalize the patient because I don't have a diagnosis? If I send the patient home, patient's condition may deteriorate. Second, am I in a hurry to give drug, or can I hold off drug because I don't have a diagnosis? So here again, judgment is required depending upon how ill the patient is, how immunosuppressed the patient is. And those clues would help you. I'm not giving you the final answer. It's a challenge. It's tough given the difficulties and the number of patients you're loaded with in a clinic, but you have to use your common sense and some of these ideas.
I asked any other faculty members to ask any questions to Professor Chandra. Kamlesh sir, if you are online, you can't ask any questions, sir.
Dr.
Professor,
Suresh,
Yes,
yeah.
sir.
Suresh, really, Dr. Chandrasekhar delivered a elaborated and a short and crisp lecture, introductory lecture, lot of learning points from him. And history is much more important than anything else, as well as lot of stories and a lot of, it's a very, very important for the public also, for the politician also, to save the people. Because if you don't take action, hit hard, hit horse rule, if you don't apply, it will end up in epidemic or pandemic. So it's very important, and methodical approach is very important. What to do, what not to do, everything is very important. So a lot of carry home message from Professor Chandrasekhar, a lot of wisdoms we learned from you, sir. Hats off to you. Really, all the audience across India, national ICP is proud of you. Lot of messages you have carried out. Thank you very much, sir. Over to Dr. Kamlesh Tiwari, sir, ICP Dean, sir. Please, sir. Your words of wisdom, sir.
thank you, Dr. Chandrasekhar, for your nice lecture. But I have got certain points. Everything you told is correct. But suppose our conditions where we are working in our outdoor, 100 to 150 patients are there. It is not possible to take a proper history. Regarding test, without writing any test, patient will show us a test of at least 300 or 400 tests in 4 or 5 pages, and they have taken from their own will and consent. Third is they will press you to write the test. If you don't want to write ultrasound of abdomen, but patient will press the doctor write ultrasound. They know that ultrasound will give diagnosis of each and every disease. So these are the problems which we are facing. So how to deal with these ones?
Yeah, I am not minimizing it. These are major challenges, actual challenges, but these have to be dealt with gradually with better patient-physician communication. It is a tough challenge explaining to the patient the importance of physical exam, importance of appropriate test, and avoidance of unnecessary test, and the limitations from ultrasound and other tests. Patient has to begin to trust the physician. Unfortunately, today, the trust has eroded. So many of the patients do not want to trust the physician when they say you don't need a CAT scan or you don't need an MRI, or the physician himself may have a vested interest. They may be owning an MRI machine, so they may be sending the patient for unnecessary MRIs. The patients read this in the newspapers. So the patients know that there may be a kickback to the physician. So all these other social issues come into very important play in trying to erode the patient-physician trust. So unless and until you get that trust from the patient, it's going to be very difficult for you to have good communication with the patient and convince the patient that empiric treatment is not necessary or antibiotic may not be necessary in this viral illness. So this is going to be a challenge, how you build your relationship with the patient.
Thank you, sir. Thank you very much.
It is not a very good answer. That's the best I can do.
Yes.
Sir, nowadays, Dr. Chandrasekhar, sir, nowadays
Yes,
in
sir.
the hospital settings, if the
Yeah.
patient is having chest pain, you have to do ECG. If the patient is complaining of abdominal colic or abdominal pain, you have to do ultrasound. Otherwise, they will go to somebody. And we are living in the litigation era also. Not only the history taking, documentation of various investigation is also very important. They are trusting the investigation rather than the doctors. So what is the proof you are telling is a typhoid? What is the proof you are having the diagnosis of scrub typhus? They are asking, what is the proof you are diagnosing a meningoencephalitis? So documentation is also very important. Not only best clinician and documentation of the various investigation, appropriate investigations is also very, very important to come to a diagnosis. We are living in the litigation era also. So nowadays, headache, CT scan, chest pain, ECG, and cough, X-ray or CT, like that. It's going in that manner in Tamil Nadu, actually. Yeah.
Yeah.
What's your opinion, sir? Suresh? It's going
Not in Tamil Nadu, everywhere,
everywhere, yes,
the
sir.
patient has become Google doctor. They see in the
It is
Google.
difficult. It is difficult. As I mentioned, if the physician is patient enough to build a healthy relationship between the physician and the patient, that goes a long way. And involving the patient's family, explaining the pathogenesis. If the patient realizes that you are saying this in the patient's interest, that would help avoid litigation. That would help patients improve adherence to whatever your recommendations are. It is the patient trust that is very important. Once the patient feels that you may have other motives, you may have other intentions, you're quick to dismiss the patient, then the patient starts demanding stuff. So it's an age-old thing. How much patience you have, how much you're prepared to explain to the patient. And another important thing, what I do in my practice, is I tell the patient, listen, you do not have a life-threatening illness today. And I'm seeing today, I will see you again in a few days' time, either over the phone or in person. Let's see how this problem evolves. Many times these are self-limiting problems. If the problem doesn't go away, perhaps at that point in time, we can take the next step. So follow-up of the patient, either over the telephone or in person, can also be a useful tool to postpone empiric procedures and empiric drug therapies.
And some days, Dr. Chandrasekhar, sir, in India, what we are seeing is actually they are hiding the history completely. If they want admission, means they are already having fever more than 7 days. And they used to go to the medical shop, Cox and MBBS doctor. After that, only they are coming to the consultant. By the time they are coming, almost 7 days over. But they will tell, last 2 days only we are having the fever. What they mean is, they are having the fever since 7 days. more severe for the last 2 days. So history also, they will cheat us actually. If you clearly sit with the patient, slowly you ask the history, they will tell all the stories. Because when the patient come to the consultant, already 7 days is over, already. So they also hide most of the histories. Very carefully listen to them and ask retrospective history. Retrospectively, you have to ask all the things. If the patient, one patient want admission, means already the patient is in sick. Already they gone to many doctors, many quacks, medical shop, everything. They put Hefixim, they put steroids, all the thing already gone in India. Because in US, Dr. Chandrasekhar used to see 15 patients. Here, we are seeing the last stage only. So many times you cannot rely on the history alone. You have to ask the history from the patient attendants also. So serial clinical examination, serial history taking, serial investigation, all the things also very important to come to a conclusion.
Thank
Is
you,
it
sir.
right, Suresh?
Yes, sir.
Yeah.
Thank you, sir. Since this is a one session, I agree with Professor Kamlesh Tiwari sir was sticking to the time 7:30 to 8:30. This is only one session in the last week.
Okay, sir. Okay.
8:45. So
Thank you,
yes.
sir. Thank you very much. Thank you
Thank you,
for the
sir.
first
We
lecture.
can
and
go on.
nice
Those who
talk.
put the messages, we can answer it, sir. Sure. In the group, we can create a WhatsApp group. So
Yes,
people
sir.
can post the questions, we can answer. I sincerely thank Kamlesh Tiwari sir for permitting for me extra 15 minutes. Thank you, sir.
Thank you, sir. Thank you. Thank you.
Thank you for having me, and lots of luck with your efforts in
Thank you, sir.
education.
Thank you. Thanks for joining, sir, today.
Thank you, sir.
Okay.
Thank you, Chandrasekhar sir, Suresh Kumar,
Thank
Thank
and
you.
Kamlesh
Bye
Dada, sir.
bye.
Bye,
Bye
sir.
bye.
Bye, sir.
Bye. Bye. Bye.